Some say obstetrics make you gain magical powers. I don't know. Maybe.
Today we will talk about multi-fetal gestation, specifically twins pregnancy. But remember that this term also includes triplets and higher order multiples. The rate of twins pregnancy is about 3%. However, it has been on the rise in the recent years, and that's attributed to two main risk factors. One of them is advanced maternal age, and the other one is assisted reproductive technology. So why do we care whether the patient is having a singleton or twins pregnancy? And that's because twins pregnancy is at a higher risk of developing complications. Some of them are fetal anomalies, stillbirth and neonatal death, gestational diabetes, hypertension and preeclampsia, and preterm delivery. This is a good spot to understand how twins pregnancy occurs. The first way is if two sperms fertilize two different ova. In this case, two fertilized ova will grow to become two different fetuses. This results in the development of a dichorionic diamniotic twins. On the other hand, if a sperm fertilizes one ovum, and this fertilized ovum divides into two separate ova, then each one of those will grow to become a fetus. As you can tell, they both share the same genetic material. The type then depends on the day of separation. If it occurs within the first 3 days, this leads to a dichorionic diamniotic twins. If it occurs between day 4 to day 8, the type will be monochorionic diamniotic. If it occurs between day 9 to 13, the type would be a monochorionic monoamniotic. And after that, it causes a conjoint twins, otherwise known as Siamese twins. This type is beyond the scope of this lecture. Chorionicity and amnionicity is best determined using an ultrasound scan in the late first or early second trimester. The pregnancy is considered dichorionic if the ultrasound scan shows a delta sign, also known as a peak sign or lambda sign, two placentae, or two different sexes. Just a quick reminder, dichorionic diamniotic means the fetuses have separate amniotic sacs and two placentae. Monochorionic diamniotic means they share the same placenta but have two different sacs. And monochorionic monoamniotic means they share the same amniotic sac and placenta. An early ultrasound scan might show a delta sign in case of a dichorionic twins or a T sign in case of monochorionic twins. In addition to that ultrasound scan, a fetal echo is recommended between 18 to 22 weeks. This is separate from the anatomy ultrasound scan that we routinely do during pregnancy. Multi-fetal gestation is at a higher risk of developing preeclampsia, therefore it's important to give low-dose aspirin for prevention. Fetal surveillance, which includes non-stress tests and assessment of the amniotic fluid, usually starts at 36 weeks, but earlier if complications arise. Timing of delivery should be individualized. It is important to involve a maternal fetal medicine specialist in the management. In case of an uncomplicated dichorionic diamniotic pregnancy, delivery is recommended between 38 to 38 weeks and 6 days. For an uncomplicated monochorionic diamniotic pregnancy, delivery is recommended between 34 and 37 weeks and 6 days. And for monochorionic monoamniotic twins, delivery is between 32 to 34 weeks. What is the mode of delivery? There are two situations where you choose cesarean section over vaginal delivery. The first situation is if twin A, which is the presenting twin, is in breech presentation. because of the risk of locked twins. And the second situation is in case of a monoamniotic twins due to the risk of cord accident. Otherwise, you can attempt a vaginal delivery if twin A is in a cephalic presentation in a diamniotic twins. At this point, let's address some complications that you might see on your test questions. Twin-to-twin transfusion syndrome is one of them. That happens in a monochorionic twins where the fetuses share the same placenta. However, due to an arterial venous malformation, one of the twins gets a lot of the blood supply and the other one does not. Therefore, one of the twins becomes very big and the other one remains small. Twin-to-twin transfusion syndrome is divided into 5 stages based on severity. This staging system is called the Quintero classification. The first stage is when one of the amniotic sacs contains too much fluid or polyhydramnios, and the other one contains small amount of fluid or oligohydramnios. That's why this condition is sometimes referred to as oli-poly. Stage 2 is when the ultrasound scan shows absent bladder in the donor twin. Stage 3 is when the umbilical artery Doppler is abnormal. Stage 4 is when one of the fetuses shows generalized edema or hydrops. And stage 5 is when there is a fetal demise of one or both fetuses. Treatment of this condition requires the involvement of a maternal fetal medicine specialist. One of the options of treatment is amnioreduction, where excess fluid is aspirated from the polyhydramnios sac. Or if the expertise is available, a fetoscopic laser photocoagulation of the AV malformation can be performed. Another complication of a monoamniotic twins is called entanglement. There is no agreement on the best management of a monoamniotic twins. However, inpatient management between 24 to 28 weeks is recommended, with daily non-stress tests, regular growth ultrasound scan, and as we said earlier, early delivery between 23 to 24 weeks.
Don't forget to check out my books on Amazon. One of them is called OBGYN Made Easy. Don't waste time on the shell, the pearl is inside, and the other one is for questions and answers. And the links are provided below. If you want to support this channel, please like and subscribe. If you have any question or any suggestions, please leave them in the comments below and I will do my best to address them. Guys, my commitment to you is to provide you with the latest information based on the most recent American College of Obstetrics and Gynecology guidelines. Thank you and see you next time.